Welcome everybody from Las Vegas. Once again, as for disclosure, I do receive an honorarium from Implant Direct for the presentation. So everything in our life, including dentistry, has to begin somewhere. Some type of beginning is necessary for everything we do. We all need to start at some point. For implant dentistry, this may be that somewhere for you, or this may just be another rendezvous point along your implant journey. So why dental implants? Well, the goal of modern dentistry is to restore the patient to normal contour, function, comfort, aesthetics, speech, and overall health, not just dental health. So implant dentistry gives us the ability to achieve this goal. So let's talk about edentulous in the world, specifically the Western world. According to the WHO and Swiss implant makers, there are 300 million fully edentulous people in the Western world. Of those 300 million people, 44% of them are in the US. That's a huge amount of edentulous people that we have to contend with here in the United States. And what do we as a culture associate with tooth loss? Well, according to the literature, age is directly related and every indication to tooth loss. So as we age, we think we're going to have to lose teeth. You and I both know that is not the case. However, our fellow man doesn't necessarily agree with that. So let's look specifically at complete dentures. So a study was done in 2002, and the Journal of Prosthetic Dentistry published a study. They were looking to see if complete dentures was necessary to teach in the curriculum for an undergraduate dental program. So they came up with a study, will there be a need for complete dentures in the United States in 2020? What they found is edentulous decreased by 10% every decade. So that would support their theory that, you know, we don't need to teach complete dentures anymore. However, this 10% decline in edentulous that was experienced each decade for the past 30 years is going to be more than offset by the 79% increase in the adult population older than 55. So the result suggests that the adult population in need of 1 or 2 complete dentures will not, in fact, go down, but will increase from 33.6 million adults in 1991 to 37.9 million adults in the year 2020. If we do decide to discontinue teaching complete dentures, there are going to be millions of patients that will be forced to seek these denture services from some type of alternative provider. So we know that 65-year-olds now will live an average of 17 more years according to the Anaheim Group, and 20% of all American adults wear some type of removable denture. If we go back to that study, that gives us about 35 million Americans that are edentulous in either one or both arches. So it's absolutely ridiculous to think that complete dentures can be discontinued in the curriculum. 20% of Americans are edentulous in one arch. That makes 7.5 million arches available. 80% are edentulous in both arches, which will give each dentist in the United States 2,400 arches per dentist. So there is a huge need for prosthetics in the future. However, you and I know that prosthetics, complete denture specifically, can be very challenging. How can we improve our patients' experience with complete dentures? That's a challenge. Tooth loss is very difficult for some patients. Do we understand how tooth loss affects our patients? I will tell you that I didn't. I just thought that, you know, Mrs. Jones, get over it. It's we got to deal with it, and then we have to replace that tooth, or we have to do that denture. But we don't understand as a profession, as a dentist, as a surgeon, as whatever you consider yourself, how this tooth loss affects that patient. Tooth loss can have several categories that allows us to talk about it. So there's some emotional considerations that are associated with tooth loss. There are some definitely nutritional considerations that we experience with tooth loss, as well as local and systemic health considerations and psychological considerations that you will have to deal with, or you do deal with routinely. In addition to those internal issues, there are some external consequences of tooth loss, some aesthetic consequences, if you will. There are facial changes that are associated with the loss of the teeth. The patient will develop a prognathic type of appearance, as we're going to discuss, due to the resorption patterns of the maxilla and the mandible. There is a decrease in the horizontal labial angles, as well as a thinning of the lips. There's also a deepening of the nasal labial groove, as well as an increase in facial lines, as well as the loss of facial muscle tone. So why implants? Why do we want to offer implants to patients? Well, one thing is it can help address some of these issues, and you can, with confidence, to a certain degree, tell your patients that will help you eat what you want to eat, as well as help them experience an active lifestyle. It will also help them smile with confidence. They're not worried about their denture falling out or into the cup, if you will. It allows them to look younger by keeping bone around, and improves overall health, not only directly, but from a psychological standpoint. When you look better, you generally feel better. So let's talk about some myths of dental implants, because they are not the answer to everything. Some frequent dental myths are that implants are always fixed, as we're going to discuss pretty soon. That is not the case at all. Very frequently am I using implants for removable situations. Another myth is that a dental implant is always more aesthetic. Oh, let's get rid of that bridge and do an implant. It's going to look better. Well, that's not the case. Sometimes I can't get the papilla to go in an aesthetic situation because of the bone loss that's already occurred. I can have this situation look better with some type of pontic, or I can have your whole overall situation look better with some type of flange because I need lip support for whatever reason. That is another myth, that it'll look better. And the final myth is an implant will last forever. You know as well as I do that everything we do in dentistry can and does have a lifespan. Implants are no different. Implants may last that patient the rest of their life, but there's a chance that that dental implant, specifically the prosthetics, but the actual implant body itself, will need to be replaced. And we need to prepare ourselves and the patients for that. So one thing we need to do, the first thing we need to do when we discuss implants and prosthetics and all these options with patients, is manage their expectations. Patient expectations are huge. If we look at our colleagues in the medical field, if we look at a hip, 80% of hips last at least 15 years, and 70% of them last at least 20 years. That means there is a 30 to 20% chance that it's not going to last 15 or 20 years, and it's going to need to be replaced. You know, when the orthopedic surgeon places a hip or a knee and it fails, patients think, oh, okay, I just need to get it redone. They get it redone, and you know what? They get paid again. Us as dentists, we tend to think what we do must last forever, and we're a complete failure if that MODBL 5-pin amalgam fails in 25 years, right? And that's something that we need to get over. Managing those patient expectations is important. Managing our own personal expectations is important as well. If we look at a prosthetic limb, they last an average of 3 years according to amputeecoalition.org, and a prosthetic eye approximately 5 years according to ericssonlabs.com. Now, prosthetic eyes, that's something I use as an example frequently when I'm doing a complete set of dentures. I let patients know, if you got a prosthetic eye, you wouldn't expect to see out of it, but patients expect to function with their complete dentures as if it were their natural teeth. You and I know that dentures are not a replacement for their teeth. They are a replacement for no teeth. That being said, we still want to give them something that is close to natural as possible. So the key is to discuss the patient desires and expectations from the beginning. If the patient has an ill-fitting or poor denture, and your plan or your patient's expectation is they're going to fix it with just getting a couple implants, or you took an implant overdenture course, so they have a bad ill-fitting denture, and you think you're just going to put some implants in there to help with resistance and retention, and that's the only thing you're going to do, your result will more than likely be an equally ill-fitting and poor overdenture now. So you need to manage the desires of the patient from the beginning and go over their expectations. So one of the biggest dental lies that we see is, again, the dental implant will last forever. Just like anything else that we do in dentistry and place in the mouth, implants are in a hostile environment. They experience extreme thermal cycles from hot coffee to cold ice cream, sometimes in the same sitting. And remember those occlusal forces that can be generated during parafunction, which are almost 1,000 pounds per square inch in some people. So we need to have that discussion from the beginning. Dental implants will not last forever. If you have a bad prosthesis and you want to use implants, you're going to have a bad implant-supported overdenture. Implants do have several advantages, though, and those are what we need to discuss with patients and focus on. They have a high success rate. In some literatures state that a 97% success rate in over 10 years, for 10 years. There's a decreased risk of caries on adjacent teeth, decreased risk of endodontic problems as well on adjacent teeth, as well as an improved ability to clean the proximal surfaces of these teeth. There's also improved aesthetics of these adjacent teeth, mainly because we are maintaining the bone. We don't have a huge defect with these large gingival embrasures. It also allows an improved maintenance of the bone in this edentulous site. There's decreased cold and contact sensitivity on adjacent teeth, again, due to the fact that we are not creating bone loss where that tooth was edentulous. We are maintaining that bone. What happens when the tooth comes out? The bone resorbs. That alveolar bone has no reason to be there once that tooth's gone. What happens when the bone resorbs? Tissue follows it. So the adjacent teeth can potentially develop recession, which will cause an increase in cold sensitivity. So placing those implants can help decrease the cold sensitivities on those adjacent teeth. Again, huge psychological advantage of the single tooth implant, and obviously a decrease of the abutment tooth loss. We cannot forget what patients want. What do they desire? When the patient comes through the door, we always need to remember the patient does not want implants. They do not want crowns. They do not want dentures. They want teeth, okay? How are we going to give them that teeth? If someone walks through your door like this, what are their expectations? Has this person been watching commercials all day long? So they have the expectations that they're getting teeth when they leave that day because they've seen the commercials. It's been a day, teeth in a day. I want to get my teeth today. What are their expectations? What do they need? What do they want? Can we transform them into something realistic like this and give them the desired outcome? Can we incorporate all of their expectations and have them avoid a traditional denture, a traditional complete denture? That is one of my goals as a practicing dentist. I would like to avoid complete dentures. I want to help maintain the bone. We need to have these discussions up front with patients. For example, this particular case, we were able to manage their expectations on removing the palate. Complete denture and a palate was a huge psychological issue for this person. And as with every other patient we have, our treatment planning had budgeting constraints. So addressing that with some type of locator type prosthesis that allowed us to remove the palate was a huge desire for this patient. So that was the expectation that this person had, and we were able to accomplish that through the discussions and through a realistic conversation with what we can and cannot do. So this is an example of an implant-supported bar overdenture with some metal transitioning to the palate, which allows us to distribute the force and remove most of the palate. Again, what is their chief complaint? What do they desire? What do they want? What are their expectations? So we've talked about edentulalism, so let's go over some basic terminology with dental implants so we can have a discussion on how we're going to restore our patients. So every dental implant has basic terminology. There's an implant body, which is what's going to be in the bone, and there's an abutment, and a locator is an abutment. So let's go over some surgical approaches that you may hear, just so we can have a discussion on that. So basically there are three ways to have the implant placed. Now this is not a surgical course, but I do want you to understand basic surgical principles that are going to allow you to be a better restorative person. If you have the desire to place implants, I would encourage you to do that. But there are basically three ways to have this implant placed. This is either going to be a single stage, two stage, or an immediate type of load. So when we talk about one stage surgeries, this is the implant body that has some type of permucosal abutment, such as a healing abutment that emerges through the bone and the soft tissue that is placed the day the implant is placed. The advantage of this is that it does not require a second uncovery type surgery. There are certain requirements, and it's not able to be done every single time. One of those generally is that it has a certain insertion torque value, and that generally is 35 Newton centimeters. Okay. The other type of surgical approach is what is described as a two-stage surgical approach. This is the implant that is placed below the soft tissue, pretty much at the level of the bone, depending on what type of implant it is, and a cover screw is placed over it, and this tissue is sutured directly back over it, and a second stage surgery is now required to, quote, uncover this implant. Okay, this, again, if you didn't have the correct insertion torque values, you may want to do that. There are indications and contraindications to each one, and as you get knowledge about surgery, you will have those decisions that you can make. The third type of approach would be what is termed an immediate placement, whether that placement is a provisional or that provisional is loaded. It really doesn't matter. It is both considered an immediate. I shouldn't say it doesn't matter. It matters a lot. It just doesn't matter on this terminology. So the immediate implies that the implant body and the prosthetic abutment are placed at the time that the implant is placed. There, again, are several other types of terminology that you should be familiar with. If you are just now getting involved in implants, the vocabulary, the terminology, all the nomenclature can be sometimes the most challenging, not only for you, but for your team as you are helping teach them. So some terms that you're going to hear are the implant fixture or the body, and is termed the Crest Module. We're going to go into that. The cover screw, the second stage permucosal abutment or the healing abutment. Anything that erupts from the implant head through the tissue is considered a permucosal abutment. The transfer abutment, the implant abutment, a prosthetic screw, an implant analog, and then we have various ways to transfer that information, whether we're using a direct or indirect method. And by that I mean the impressions that we're going to take. So let's take a look at the implant body, or the fixture as some people would say it. That's another thing that makes it difficult, is there are several words, terms for the same thing, just like anything else in dentistry. So things you need to know about the implant body or the fixture is the length of the implant. As a surgeon, that's important. As a restorative dentist, it's not that important. It is important on when we're talking about longevity and stability as far as treatment planning, but if you are just restoring and you need to order parts and pieces, it really is of zero importance. Okay, what is important is the platform diameter, and that is not to be confused with the actual diameter of the implant. This, for example, is an Implant Direct Legacy. The platform diameter and the implant diameter are two different sizes most of the time. So, for example, an implant of 3.7 diameter on the body, the implant diameter will have a platform diameter of 3.5 for this particular implant. When you get into placing them, you will also be introduced to something called the Y value. The Y value is the extension here of the tip of the drill. This is not included in the length of the implant. If you place a 10 millimeter implant, that 10 millimeter length generally stops right here on that drill. Now again, this is not a surgical presentation, but these are things you should be familiar with. So let's get into the business end of the implant. This implant has what is termed a collar. There are various designs for this collar. These are straight, flare neck beveled, reverse beveled, tapered, smooth surface, micro-threaded, etc. There are several different types of finishes for these collars. And depending on what your philosophy is, you will choose whatever is going to work best for you. What is more important is the actual internal, I shouldn't say that, but for an ordering standpoint, if you are restoring these, what is going to be important is the internal portion or the platform portion of the fixture head. I personally like the Legacy product by Implant Direct. It is an internal hex pattern, and as I mentioned, there are different diameters of this fixture head according to whatever size diameter you are going to use for the implant. For example, you'll see here the fixture or the platform for both of these implants has the same fixture head. Again, this one has one. This one, both of these diameters of the implant have the same platform size. So that is one advantage of the Legacy system, is there are several diameters that have the same platform. One thing I like about this system, and a lot of systems, most systems are like this, is all the green, no matter what the diameter of the implant, all the green are the same. For example, with the Legacy, this is a 3.5 diameter. It doesn't matter what it is, so for whatever reason, if you do not have that information by the placing surgeon, and you look in the patient's mouth and you remove the healing abutment and you see that it's green, you know what size automatically platform that is, assuming you know what implant you have. So again, that is a huge advantage, having them have the same platform diameter. So the 4.2 and 3.7 body diameter both have a 3.5 platform. The 4.7 and 5.2 have a 4.5 platform, and the 5.7 and 7.0 both have a 5.7 platform. Like I said, most implant companies have the same type of system, same platform sizes for various actual implant diameters. So when you are restoring your overdentures or your single tooth denture, or I'm sorry, your single tooth implants, that's what you need to know, is the platform diameter size, not necessarily the size of the implant itself. If we look at the Legacy 2 a little closer, it comes packaged like this. There is an impression transfer that it comes with, as well as a cover screw and healing abutment, depending on what you decide to do. I was taught my first 50 implants, always put your cover screw on. It allows you more surgical experience. It just lets you deal with the tissue at a second appointment. So that's what I did. I used the cover screw exclusively. Now there's lots of reasons that I'm going to use it. So the cover screw will be used frequently in that two-stage type of surgery. Again, the disadvantage of that is it requires a second stage. That is, in my opinion, when you first get started, more of a disadvantage for the patient and not necessarily you. For you as the surgeon, it gives you that second experience on opening your flap again, and seeing how that bone is going to react to the implant. I think that personally is really important, is as you are getting to know an implant system, how does that bone react to that implant? If you go back in there to remove the cover screw and place your healing abutment, you get to see that, okay? So you, when the cover screw is placed, it's flat, tissue gets sutured over, and that's that. The healing abutment, again, is placed on the implant platform and extends through the gingiva and is termed the permucosal extension. A locator is an example of a permucosal extension. So one thing you will hear often is a microgap. The microgap is the crevice between the implant and the abutment, okay? It's important in dentistry. Even though it's at 0 microns, that is, when we talk about biologic width, that is generally where that biologic width is measured from. Regardless of whatever implant system you choose, I personally think you should choose one that gives you the most options for your prosthetic choices, okay? For example, this is the Legacy platform that's showing right here, and these are all the various prosthetic options that you have, including the locator attachment, okay? So you are able to use a locator or a healing abutment. You can put a standard abutment on there, stock abutment, if you will, custom abutment. You can make a screw retain crown, use some type of ball attachment, or a traditional locator attachment. So that, in my opinion, when you are choosing what implant system you want to start with, you choose the one with the most prosthetic options, okay? So let's talk about some of the surgical components and some of the surgical requirements of implants. Facially, lingually, you want to make sure that there is at least 1 millimeter of bone on the facial and the lingual. Ideally, you want as much as you can, and when you first go over treatment planning, that is going to be one of the things you're going to look at is how much bone do I have. So 1 millimeter is minimum. When you start looking at implants in between teeth, you want 1.5 millimeters away from an adjacent tooth, or you want 3 millimeters of space between adjacent implants. So as you are treatment planning with certain cases, keep that in mind, even if you are not the surgeon. Classic example is someone congenitally missing a lateral incisor. The orthodontist will send them to you for the checking of that space. Is this where you want it? Do you have enough space to put your lateral incisor here? And sometimes, yes, it looks great, but you need to take a radiograph and see, do you have that requirement? Can you get an implant? Did the teeth, adjacent teeth tip, or did they bodily move? So you need to keep that implant at least 1.5 millimeters away from the adjacent teeth, okay? So we have the implant, we know about the implant placement, we know what options we have to go on the implant, so now you need to be able to transfer this material to the lab, and we use impression transfer copings to do this. They will either be closed tray or open tray, depending on how you want to do it. And another word you're going to hear a lot is the analog. The implant analog is what represents the implant in the stone model. So this is something that either you can put on or you have your lab do it. So single tooth implants have helped us confront and address several of the issues of tooth loss that we discussed previously. It allows us to do overdentures. There are some advantages of implant supported prosthesis, such as it helps maintain the bone. It helps maintain and restore the vertical dimension of occlusion. It helps maintain facial aesthetics and muscle tone by keeping the teeth in that position. Increase the success of your prosthesis. A huge benefit is it can reduce the size of your prosthesis. You're able to get rid of the palate and get rid of some of your flange extensions. It allows you to provide a fixed or removable type of prosthesis, and a really important one is that it improves the stability of these removable prosthesis. So facial aesthetics can be enhanced with a labial phalange of a removable prosthesis because not everything needs to be fixed. So one advantage is the prosthesis can be removed It can be removed to manage nocturnal parafunction. It can be placed if there's nocturnal parafunction to help reduce some trauma to the opposing arch. If you are worried about implant positioning and you want to use a removable prosthesis, that position is not as crucial with the removable, but we still have certain requirements. And financially, you may be able to decrease the amount of implants, therefore decreasing the cost of the implants. So there is a large body of evidence that supports the proposal of a 2-implant supported mandibular overdenture being the minimum offered to edentulous patients as the first choice of treatment. And that word standard of care gets thrown out quite a bit. Now, I don't know that I would stretch so far to say that a 2-implant mandibular overdenture is the standard of care, but it is a huge benefit for people and should be offered as one of your main choices. So another study looked at the quality of life that patients with dentures had, and they found that their analysis illustrated patient satisfaction to be great, and their oral health-related quality of life was increased with mandibular implant retained overdentures as opposed to conventional dentures. So talking about overdentures, there are several advantages of implant overdentures. It's going to retain the bone in the area. Something called Wolff's Law, it stimulates the bone to prevent more bone loss. It improves the stability of the implants. It helps with the occlusion. It improves chewing efficiency and force, improves retention, support, speech, helps you reduce the size of the prosthesis, like the flanges. When we are talking about treatment planning these, Mish, in his textbook, divided these ideal spaces through his testing into 5 separate sites. He looked at the available bone in the anterior mandible and divided it equally into 5 columns, serving and labeled as sites A, B, C, D, and E. So let's go through a case here. We have a patient that is going to be fully edentulous. Here is where we want to place our implants in with the blue here. So those are going to be sites B and D. Remember the requirements for our implant. Like I said, even if you're not going to be doing your surgery, you should be familiar with the requirements of the implant. Basic flap design, our blood flow is going towards the center, so we want to stay on the crest of the ridge for this type of incision. And once we open it up, we notice that there is some thin bone, and we knew that from the CBCT. So we can flatten the bone to help increase the width due to the triangular shape of the anterior mandible, place a cover screw, and close it up. So again, remember our requirements. If we were not able to flatten that bone, we would not be able to obtain our 1 millimeter on both the facial and the lingual. So in this particular situation, a cover screw was placed and it was sutured closed. Okay, so what type of overdenture do we want to do? There are several types of overdentures. I'm going to talk about one specifically, which is the Locator. Okay, the Locator is by Zest. It is my favorite overdenture. Okay, it's a great option. It can be used with a single tooth type attachment, as illustrated in this drawing here, or it can be used with multiple implants and placed on a bar to place those locators in the exact position you want them to. So let's talk about some of the anatomy. Again, this is showing single tooth versus a bar. Let's talk about some of the anatomy of the locator. There is a male and a female portion, and it actually is the opposite on what you would think. The upper portion, what is labeled the male, that's what goes in the intaglio of the denture. It is considered a male due to the insert here that goes in the female portion on the abutment of the implant. What you need to know is the difference in the height of the cuff. Every locator you place is going to have a different type of cuff height. You are going to measure that in your patient. You're going to measure from the platform, the top of the implant, to the top of the tissue. So this is one of the two things you need to know while ordering whatever you need to order for your implant overdenture. You need to know, one, what is the diameter of the implant, and two, what is the cuff height or the height of the tissue. One good thing about locators is, although all these thread patterns here go into whatever implant, all the diameters on these gold portions here are the same for everything. You don't. It doesn't matter whether you have a Nobel or a Zimmer or an Implant Direct. Whatever you have, implant you have, these portions are the same, meaning the inserts that go over top of them, the male portions, are going to be the same. You don't have to have different ones. So you're going to measure the cuff height, and be aware that the little top portion, the female portion, there's 1.78 millimeters that is not added and counted and measured when you're measuring your cuff height. So where do you want to measure this? You want to measure from the top of the implant platform to the top of the tissue. You can do this with an existing denture using a CBCT and a radio-opaque material, or you're just going to measure it at your uncovery if you have a 2-stage, or if you're healing abutments placed, you just unscrew it and measure it with a perio probe. Pretty easy. So the locator male portion has a little insert that goes in the intaglio, and that measurement is 2.35 millimeters. And as I mentioned, that is actually what goes inside of the denture. The different locators, regardless of whatever size implant you have, there are different retentive strength, what we call nylon inserts for them. Now, there is a standard type of locator which ranges from 0 to 20 degrees, and that refers to the angle of the abutment as it's emerging. Are these off or are they on? And there's also an extended range one, and you can have up to 40 degrees difference. Each one of these different colors has a different strength, and you can mix and match them and do whatever. So this is a traditional locator. There's also the RTX type of locator that allows for up to 60 degrees. However, all those inserts are different. Now, what are you going to do? How do you get this impression, these locator inserts, into the denture? Well, you simply snap on the impression copings while you're taking your final impression for the denture. That is one way to do it. Simply use your whatever technique you use for comprehensive or complete dentures and make your impressions. The advantage of that is every step from now on, your wax rims, your try-in of the teeth, they come back with these inserts in there, and you can now snap on, if you will, every step. So you don't have the wax rim flopping around, and that is a huge advantage. Another way you can do it is go to completion with the denture and pick up these attachments intraorally. Okay, so clinically, again, you can have the lab make these, or you can just do it yourself after the denture is processed. Okay, so you create an axis in there, and we'll go through that in a few minutes here. You can also reline existing overdentures. One thing that is mandatory is the locator core tool. Okay, the locator core tool is one thing that you must have. This breaks down into 3 sections. There's a removal portion, an insertion portion, and a placement portion. Okay, you cannot do anything without these types of instruments, these tools. So the placement portion is used to actually torque down the abutment, the locator abutment, and you torque them down to 35 Newton centimeters, what I use, and you use your 1.25 millimeter hex to go in there. So one advantage, again, is once you torque it down, everything comes back with the locators already attached. Again, using the removal tool, you're going to remove the black inserts and take them out, and then use the insertion portion to place your new inserts, your retentive attachments. So again, you're going to use the removal section, snaps those out, and there's a little lip on there that you're going to grab it with, and then you're going to use the insertion portion to place them. So it's very quick. Something your assistant can do. Charge a fee per insert to replace them, and we recommend once a year for that. So let's go through a case. It seems like we're running out of time, so let's go through a case here and we'll finish up in a few minutes. Always want a treatment plan with the end in mind. This is a case done by a colleague of mine, Dr. J.B. White, a local dentist here in Las Vegas. Hopeless prognosis for the mandibular dentition. Let's look at our CBCT and see where we want to place our implant. Even if you are not doing the surgery, this is something you need to know. How much, what is realistic? Where can we place these implants? Remember, we need at least 1 millimeter of bone, both facially and lingually. So if we go through our site selections, A, B, C, D, and E, this is showing a cross section, a Legacy 2, 4.2 by 13. Now, looking at our site selection, we didn't talk a lot about the surgical process, but if we look at this position in the first cutout, we have to contest with a huge labial undercut here, as well as a lack of bone on the lingual. So if we go and place that to a more desirable position, that will allow us to put it in the proper position for the surgical requirements. However, if we do that, the head of that is pretty much at the apex of the existing tooth. That's 8 millimeters apical to where we need to place it. So it was decided to place it there to avoid that concavity. The first side was done, the alveoloplasty was done, and you can see it's 8 millimeters from the crest of that alveolus, that ridge. Continue on and finish the alveoloplasty to where we need it. Again, we are transforming that bone from a very, very thin to a fatter, wider area of bone due to the triangular shape of the mandible. So this is showing one of the drills placed in the midline, and this is used as a reference point. When you don't have any teeth, sometimes you lose your references. So one technique is to place your a drill or something in the midline to allow references. Now the implants can be placed in the B and D position respectively. At that time, you need to decide, what do you want to do? Do you want to make this a single stage and place your healing abutment, or place a cover screw? In this situation, a healing type abutment was placed and used, a permucosal type of abutment, and a locator is a permucosal type of abutment. So that was actually used at this time. So the locators are placed and it's allowed to heal. Now you don't have to go back in and do any type of second surgery. It is ready to go. So this is about 3 months later. Whatever your philosophy is on that, you wait your time. Now you need to start the denture. Okay, so you have the locators from the occlusal view. Place your impression copings over those if you want to do it the laboratory way, which I think is a fantastic way to do it. Use your standard denture impression taking techniques. One thing is you should use an elastomeric impression material. If you're using like a system 1 or 2 alginate type thing, that makes it a little more complex because now you're doing more of the work. So place your impression copings, make your impression, and everything is exactly the same. Nothing is different except now you have these locators and the inserts that you can attach them to. And then you go through your denture process and make your denture. Same thing for the maxilla. Have the thin labial bone, and of course that fractures. So I decided to actually graft that with a titanium reinforced cytoplast membrane, suture it up. This shows that membrane, and it was necessary because of my treatment planning to do that because I needed the space. But do we need that space? What do we need for our prosthesis? Okay, well, it depends. Are we going to use a locator? Are we going to use some type of clip? Or are we going to use a hybrid type of restoration? So the most important factor in implant overdenture success is the prosthetic space. Okay, if you have insufficient prosthetic space, you're going to run into lots of issues with fracturing. Okay, so that space for an implant retained locator is 11 to 12 millimeters. For a bar and clip retained overdenture, 15 millimeters of space is required. And for a fixed detachable or quote hybrid type of all-on-4 type of restoration, 18 millimeters of space is required from incisal edge to platform or crest of bone for the implant. So how do we find this prosthetic space? One way to do it is if you have an existing denture, you can line that with some type of radio opaque liner like green mousse. This is a technique done by Dr. Shear that he published in the Journal of Prosthetic Dentistry. You line it with green mousse, you use cotton rolls to increase the airspace, and that gives you a representation of the prosthesis, the intaglio anyway, of that prosthesis. Another way you can measure it is simply measure with some type of caliper whatever denture prosthesis they have. One disadvantage of that is if they don't have a denture prosthesis, you can't do that. Regardless of how you do that, you need to create a treatment plan that is driven by the prosthetics. Start with basic denture principles. How do you start with your complete denture? You're going to do that with your overdenture. Remember, how does the alveolar bone resorb? In the maxilla, palatal and apical, and the mandible, lingual and apical. So you are creating this pseudo class 3 type of appearance, which is going to complicate that. So always start with a denture. Do not place the implants first and then work up your prosthesis. Even if you have to fabricate an interim denture, again, communicate, go over expectations with your patient. One last thing we're going to talk about is relining the denture. You will run into that frequently with some that not only you did, but they come in with the locators already attached. You're going to use the black processing inserts that come with the little kit that you will order, and whatever the metal male portion that is in the denture, you're going to insert the black processing rings into that so there's no retention on it. Use adhesive, just like you're using a tray. If you're using PVS, use a PVS tray adhesive. Border mold if you need to, and then you're going to wash the rest with monophase. For example, this was one that there was probably 6 millimeters of space, almost like a high water type of locator system, if you will. So I had to border mold the labial and lingual portion and then cut that out, as is showing on this lower picture here. Cut that out and then actually wash it, the intaglio, with a monophase type material. Then it comes back to the lab and you just pop in your inserts and try it in. You're going to deliver it using the locator tool, remove the black laboratory inserts, and whatever color for the retention you need, insert those using the insertion tool, and then check the retention. You may need to change those. There's no rule that says if you have 4 overdentures, all 4 have to be the same strength. There are times that I've actually used the black inserts as one of my retentive inserts because there was too much retention that was obtained. So very simple process. Thank you for your time and attention. It's a lot of material that we covered, but I would like to open it up now to any questions that you may have over overdentures or implants in general. Okay, I got some questions here. Let me open that up. What is the benefit of using the bar with locators instead of directly on the single tooth? Well, there are several advantages. One advantage would be if you have maybe implants that are extremely divergent. They're kind of all over the place. Maybe it wasn't really prosthodontically driven, and for whatever reason, implants were placed just haphazardly. The bar will actually allow you to control that, and you can place now the locators wherever you want. Another one would be, in the example I showed, I didn't go into the whole history, but that person actually had bilateral sinus grafting done, and they both failed. It was done by the surgeon. They both failed, and they didn't want to go through it again. So I needed to gain some posterior support. So we used a bar to, one, gain that spread, the AP spread, and two, place the locators in a position that were going to be the most ideal as far as retentiveness. So it's going to allow you to correct for extremely divergent implants when you can't use direct locators. So another question is, do you like the new RTX locator at all? And my answer to that is I haven't used it, so I cannot speak to it. I have several colleagues that have used it, and they have been happy with it. I personally don't have any experience with it. One reason is I've done it intentionally, because everything that is required from the restorative end of it requires different instruments. You need a different insertion tool. All the, nylon inserts, the male portion that snaps in all those different colors, with the standard locator, they're all the same no matter what height your locator is, no matter whatever you do. You order the same one. You can't use those with the RTX system. So I do not have any experience with it, but the word on the street is that it's pretty good. Another question is, what type of burr do you use for bone reduction of the ridge? That really depends. So I have a burr that we call the lawnmower. It's actually a KS burr, Coy Spears burr. It's like a football. It's a diamond burr, and you'll hear some people say you shouldn't use diamonds on bone because of the heat generation, and I would agree. However, you need to irrigate copiously to keep that heat buildup down, as well as make sure that you have a surgical handpiece so you're not blasting air and water under your flap to create issues with that. So I generally use it's a KS diamond burr for that on a surgical high speed. Next question is, what is the strength of evidence supporting routine use of CBCT for planning placing implants in the anterior mandible for implant overdentures? That's a great question. That is one that is debated everywhere. Me personally, I have never placed an implant without a cone beam. That is just my philosophy. I personally think there's too much access to cone beams for you to not do it. Before I got my own cone beam, there was an orthodontist down the street that I would send them to, and they would come back, and I just think it's worth it. And when you start talking about radiation safety, it doesn't bother me, the radiation. I use an ICAT Flex, so it's a low dose radiation, but it's mandatory when you start placing implants. If you ever have an issue and God forbid it ends up with legal problems and you don't have a cone beam, there's no excuse. So the strength of evidence supporting the use, to be honest, I don't know. I think that you need to do what you think is right. So do you protect the locators with something during the 2 to 3 month of integration? No. What you will do with your denture is hollow it out. So you don't put anything over the locators themselves, but the intaglio of the denture, you're going to cut a little relief area. That is basically what I do. I have had in situations when I've had good torque value, I've cut a relief and used co-soft, like a soft liner, to go around it, and it actually gives you a little retention without, quote, loading the implant. I don't do anything to protect the locator. I just cut a space, a relief area in the denture itself. Next question says, please discuss your preference or lack of preference for using fresh extraction sites to receive implants intended to support the implant overdentures versus using heel bony sites. That is, again, that's a great question. My answer is really dependent on each individual situation. If I can do an immediate, when I say immediate, I mean immediate placement, extract the tooth and get the implant where I need it to go for the restorative plan, then I'll do it. If I can save the patient an appointment, then I will. If I'm having a hard time getting the implant to go where I need it to go for the prosthetic restoration, I will let it heal and come back. I do not want to let speed or the determination of placing the implant at the time of extraction for the sake of just placing at the time of extraction take preference over the best outcome possible. If I can do it, great. If I can't get the implant where I need to go because it's bouncing around or I can't get a good, purchase, if you will, then I'm going to let it heal. The next question says, your success with unsplinted maxillary overdenture. I haven't had issues with, I'm assuming you mean splinted with a bar via single. I have several of both. One rule of thumb is for maxillary arches, if you want to get rid of the palate, you need a minimum of 4 locators. 6 if you need it. Some people say 6 is an overkill. If you go through some of the literature and textbooks, they will a lot of times say 6 is the standard. But 4 to 6, 4 being the minimum. Unsplinting them, I haven't had an issue. That being said, I do not have any overdentures with more than 10 years of recall. So what is the force of those individually? That's to be seen still. They are taking some forces that we just don't know what's going to happen. And there's going to be huge differences on each clinical situation, depending on what it's opposing. Is it a natural arch? Is it a denture? So I haven't had any issue with non-splinted ones. The next question is, how often do you CBCT for case planning? For implant planning, every single time. For comprehensive, for example, like a full mouth crown and bridge rehab, depends. Next question is, do you recommend metal denture base in all cases of overdenture? Not necessarily. So if it's going to fracture and it has a metal mesh, it's still going to fracture, it's just going to hold it together. I would like to have some type of metal, specifically on maxillary ones, to finish the transition from the palate to the prosthesis. So on the lower, the most important factor is prosthetic space. Yeah, it's great if you have a metal, but not mandatory, okay? Again, it's going to be depending on what they're opposing. If they're opposing natural dentition, oh, you better believe it. Yep, I want it. So not always. I think I personally, upon treatment planning overdentures, all my overdentures have some type of metal mesh in them, but it's not necessarily required. I've done some without and repaired and replaced some without, and they've been fine. So what would be a reasonable fee for a 2-implant overdenture and a 4-implant overdenture? That's going to vary drastically. We can talk about that for hours and hours and days. It's really going to depend on what you have to do. What are you dealing with? I like to live by the philosophy, one miracle at a time. So sometimes you just can't do it for a low fee. You have to get reimbursed and compensated for what you do. That depends on what that means to you. What is your overhead? I will tell you, I can give you some ideas for a lower implant overdenture. When you're doing an overdenture versus a conventional denture, you need to charge more for that prosthesis. There is more involved in that. So if we're talking about implants and the actual prosthesis, you're probably looking between $10,000 and $15,000, and that you're going to have arch or complete. And again, that really depends. It's not unreasonable. Our average fee is about $10,000 per arch for the implant and the overdenture, a basic one, a 2. Next question is, what about placing 4 implants on the mandible, 19 and 30, as well as the anterior? That's a great question. So the question is, we talked about A, B, C, D, and E positions. What about adding some behind the mental foramen? So yeah, go for it. When we are splinting things together, there is something in the literature called mandibular flexure. Whether that's an issue or not, that's for discussion for another day. But I think that's a really good way to do it. If we put 2 implants in, say, the B and D position, then place 1 in the first molar or second premolar position, you're going to get great retention and resistance. You're almost making that, some would argue you are, turning that from an implant and tooth-borne to strictly implant-borne with 0 support from the tissue. So one thing you will run into that you need to bring up with your patients that I didn't mention is one disadvantage of just using 2 implants, and it's going to, again, depend on lots of things. One is the arch shape and size, which I had to cut out for time. If you have implants that are pretty much in a straight line, if you're B&D positions and they have a U-shaped type of mandible, they may get rotation and it may lift in the posterior. Adding those 2 implants are really going to help. I would recommend always talk to your patients that here's a problem, here's an issue with 2 implants, and I do this. It may rock, it may kind of want to lift up in the back. If that happens, then the only way to take care of that is to add more implants in the posterior. So I think that's a great way to do it. Again, this is a great question. The next one, should we warranty the implants for the patient? That's a personal choice. I personally warranty everything I do within reason. Everything has to be within reason. Now, if you didn't place the implants, I'd say, no way, Jose, right? You need to have, if you're not placing them, you need to have a really, really good relationship with your surgeon, because you guys need to discuss all this stuff. Remember, the most important factor on overdenture success, specifically for locators, is prosthetic space. So if not enough alveoloplasty is done, and you have a really thin, you have 8 millimeters instead of the 11 or 12, guess what's going to happen? That's going to break. And when it breaks, they're not going to go to the surgeon, they're going to come to you. If I'm doing the implants, I will warranty them to a certain degree, which I think everyone should do with all their work, okay? Next question says brand of adhesive and how to use it. I'm assuming you meant adhesive, or you mean adhesive for relining. It's just whatever tray adhesive you would use for whatever material. PVS, polyvinyl siloxane, has one type of adhesive, and polyether has another, and alginate has another. So whatever you're using, make sure it's that adhesive. So go to whatever your dental supply house is, Shine, Patterson, whatever, and just get, if you're taking your reline impressions with polyvinyl, just get a polyvinyl tray adhesive, okay? And then you're going to put that on like you would a standard tray. Next question is your thoughts on 6 to 8 millimeter length implants for overdentures. So that's actually a great question. Talk about length, and 6 to 8 millimeters is a pretty small size. One of my goals is to place, when I'm placing implants, is to try and get 10 millimeters minimum in length. Not always possible. I placed a 6 millimeter implant in a molar area, and it's doing well. You have to compensate by trying to get as wide as you can. Again, I have no issues with it as long as it's planned properly. What I mean by that is, what's it opposing? What's the quality of bone we are placing it in? Is it a type D bone where it's like balsa wood or styrofoam, you know, or is it like maple or oak? That's going to have an impact on it. So if you only have enough room for 6 to 8, go for it. I think that, again, assuming everything is going to be working properly, I think that there's evidence to support it. So next question says, if the implants are not parallel, what type of locator or insert to use? It really depends on how parallel they are not. How divergent are they? Remember, the standard locator can give you a range of up to 20 degrees, and there's an extended range that does not, and we're just talking about the inserts. The actual abutment that you screw on the implant is the same. The only thing you need to worry about, that's what's so great about the system, are the little inserts you snap in the denture. Remember the male portion, it was called a male because there was that little portion that's stuck into that little hole in the top. The extended range locators that go up to 40 degrees, they don't have that little nipple, if you will, and so it allows you to extend that pretty far. So it depends on how divergent they are. I carry mostly the extended range, not because they're divergent, but because that little insert is not there, and sometimes that will actually fold over on itself. So next question says, which planning software do you use? I use Anatomage. It's a great software, allows you to pick whatever implant you want, and I love it. So next question says, can you pick up the impression copings with ZOE impression material? Anything that's going to hold it. ZOE works really, really good for like flabby ridges on the maxilla. If you cut that out and like start to paste it, I would say if you can hold that on there and it not move, the answer would be yes. My thought would be you may have some difficulty. But whatever you're going to use, as long as you have that space there and it's going to hold it, go for it. You may need to try and maybe make some more mechanical retention, but it does have a big mushroom looking thing on it. So next question, why can't you use existing denture if it fits well? You may, assuming you have the proper restorative space that's required. If it doesn't fit well and you think just placing implants is going to improve everything, you are going to, and the patient are going to be disappointed. If it fits well, go for it. You can use it. So, what is your opinion in unilateral implant-supported dentures, replacing 5 teeth with 2 implants? Locator. Any complication you can think of. Locators are not only for complete dentures. They can be used for partial dentures as well. If you have a bilateral or even a unilateral distal saddle, you can put a locator back there and have that snap on there. It works really, really well, so works good. I have tried to use the lab inserted locators and I've always had to remove the cans and pick them up with the Relined materials. The secret to making the lab placed ones work better. Yes, there is. One thing that can happen is the impression copings look like the little mushroom. That mushroom, that silver mushroom, has a black insert that you snap on the locator. What happens frequently is that little insert will be moved a little bit, meaning it will not be snapped in all the way and it will be kind of off a little bit. If that's off, you're going to have the exact problem you just mentioned, and that's happened to me as well. So make sure that that black insert is in there nicely, so when you put the impression copings on, check it. Just really make sure that everything is even around there, and that should help you. There's always something that you just don't realize what happened. Very rarely do I have that issue, but if you do, then you have to pick it up. Another question says, do you see an issue with mandibular flexure when connecting one posterior side to the other posterior side? So I alluded to that earlier. I do not see that issue with locators. That has been mentioned when we're talking about a fixed type restoration, okay? So that could be potentially an issue, but not with locators. Question says, if teeth are extracted and implants placed, is there a temp attachment to the locator for transitional denture? No. You can use the laboratory, the black ones, or just hollow it out and don't put anything in there. Next question, what are your thoughts on minimum number of implants for fixed on the maxillary and mandibular? I know Mish says ideally 7. We're talking about fixed. It depends. There's too many. I do not have one specific number that I'm going to say, oh, it has to be this all the time. There's too many variables to have that type of thought process. Depending on what it's opposing, what's the bone like, what's the patient's health history, what's their facial profile, what are their masters, like it really, really depends. And it depends, what are we trying to do? Are we doing a hybrid all-in-4 type thing? Too many variables to give you an honest answer with support for that, research support for that. Next question is, how many implants for the upper arch versus the lower arch? Like I was mentioning before, there are lots of variables. I'm kind of contradicting what I said, but for the upper locators, minimum of 4 if you want to get rid of the palate. For the lowers, minimum of 2. Again, depending on the shape of the arch, the type of bone, all these other factors may depend on if you increase that number. But for the upper, that being said, I did a course this past weekend, and there was someone who said they never get rid of the palate when they're doing the course, and they were asking me about that. That's one of the benefits of using the locators is you can get rid of the palate. So if you're having an issue with retention, then you may need to increase. The next question says, what kind of chairside material do you use to pick up the locators in the existing prosthesis? I didn't catch it. I'm sorry, I zipped through that because we're out of time. But there's a material by Zest called chairside, CHAIRSIDE. It is great. I mean, it is one of those things where it's like, oh my God, I can't believe I've never used this before. It is actually a resin, like a BIS GMA type resin, that does not require a bonding agent. Traditionally, I would use cold cure acrylic and do that, and salt and pepper it, or I would just inject some and let it sit there through a window. This chairside is awesome. It mixes in a self-mixing tip, and if you have a window there, which I would recommend, put a window in there so you can actually see that it's seated. You can actually cure it with a light, so that works really well. But it's chairside, and you can get it through Zest. Next question says, any tips for all-in-4 case of upper with not enough space for denture placements? If you don't have enough space, you need to create space. How do you do that? You need to take bone away. That is one of the disadvantages when we're talking about a hybrid type prosthesis. It requires that greater amount of space for the restoration, because we not only have to account for the tooth, we have this metal bar that goes in there. We have the housing of the prosthetic components. So instead of needing the 11 to 12 millimeters, we now need more like 18 or more millimeters of space. If you don't have that, you have to plasty the bone away. That's the only way to do it, or open their bite, which is probably not what you want to do most of the time. What is your opinion of Zest's mini implant system with locators? So Zest has their own system called the Lodi. They are what are called the mini. Technically, by definition, anything I believe less than 3.0 in diameter is considered a mini. I actually think they're a really good system. They have a nice technique, just like other minis. I think they're fine in the right situation. If the mini is being used just because it's a mini, I think that's a problem. On the mandible. In the maxilla, however, I do not think they perform very well. Another question is, do you have a preference for a CBCT manufacturer? What is the most important factor when choosing one machine over the other? I don't. I looked at several when I got mine. I was personally got to look at what you're looking for. I wanted a system that the patient could sit down in, especially if you start looking at what you want to do. If you have patients that maybe they have some issues with tremors and they cannot hold themselves steady and now they're standing, it can make for a difficult image. So for me, I wanted something that you could sit down, and there were only a couple at the time, iCAD and Prexion. So that was important for me. The software I use, which is Anatomage, you can use with any DICOM image. That was important. So you can get great images on, they're getting so cheap now, you can find used ones for $30,000, With hybrid restorations, what is the ideal recall time for Prophy? How much should you charge for that? Yeah, it's funny. We actually had this as a topic in our team meeting today at the office. So my recommendation we have is once a year. I'm going to see them once, even with the locators. My on-the-record recommended time is once a year to replace the inserts, the nylon inserts. I tell them once a year. That being said, I've had a patient in the same inserts for 4 years, and that's not normal. She just doesn't want to come in. She says they're fine. They don't give her an issue. My recommended time is 1 year. How much you should charge for that is going to be dependent on what you do. So, for example, for locators, my assistant replaces the nylon inserts, and we charge $25 per insert. I come in and make sure that there's no issues. I like to take radiographs around the implants just to make sure there's no issues with bone loss. And we do clean the locators. Calculus will form and attach on the abutments. So we have a standard implant fee, a Prophy fee for locators. I don't remember what that is, but determine what you need to cover your overhead for that amount of time, however long you think it's going to take, and then do it. If there is not enough bone in the maxilla and or the patient can only afford 2 implants on the maxilla, is it okay to do an overdenture with a pallet? So I would say, what are you trying to accomplish? If you're trying to accomplish an increase in resistance and retention, yes. If they think that it's going to allow them or allow for them to have like a huge difference, maybe not, okay? But I would do it with the expectation that we are going to be placing 2 more at some time later in life. If they cannot afford it, that's one thing. If there's no bone, how can we get that bone there? Can we graft? Can we do some expansion? What can we do to get that bone to where we need it to be? So I don't see any more questions. Someone asked me about the locator tool. If we're looking at the locator core tool, this is the locator core tool right here. It has 3 separate sections and they all unscrew. This section right here, so there's a threaded portion and it's flat. This one has a threaded portion and it sticks up. That little stick up portion goes into the removal section. Reason being is the removal section has a little pin that pokes out, and if you don't have this in here, it won't push that pin out. It'll only take you a couple times to figure that out. So this little plastic piece is new. This actually holds the abutment inside here so it doesn't fall off. It's almost like a little washer. If we look at how the tool is used, this placement portion here, everything unscrews. This is what holds the abutment in, and I generally just put them in by hand with my fingers unless they're super small, like a 0, and then I'll use the tool. Use your 1.25 millimeter driver that goes into this, and this portion here locks into that. So then you're going to torque this abutment down to the implant itself. That is what the placement portion is for. And this is a, you see the little arrow on here, I have it set at 35 Newton centimeters, and then it breaks when it does that. You use the placement portion for that. Someone asked the question about having an issue with it, the little black insert right here. If it's a little thicker on this side, then it's twisted in there a little bit. Make sure that's just super snug, the black insert to that, because if that's off a little bit, you will get a poor impression. And when you take your impression, it's going to look like this. There's going to be some inserts in there. So we talk about our core tool. The removal end, you can either screw back on and use it with the long handle, but there's a little lip on here. I will tell you, when you first start using this, there is a little technique to it. If you just put this in here and pull up, you're not going to pull it out. There's a little lip that you have to kind of grab the edge and kind of rock it out. And once you get it out, it's stuck on there like that. And then you're going to turn that little handle, and that little nipple is going to pop out and push this off. So that's 2 of the 3. Now the third piece is the insertion tool. You're going to use that part that goes into this, and the nylon housing will be placed on that, and you simply put it in and push. It will make a snapping sound, and you have to put a good amount of force on it. It's sort of intimidating the first couple of times you do it, but once you do it, you will realize what type of force is necessary, and you just rinse and repeat. Somebody asked about the material. It's chairside, and that's what it looks like for picking them up. If you're picking them up, I would recommend putting a hole in here. I have photos, but I just took them actually yesterday when I did this on one. This is one, it's a vent for the excess material to come out of, but I want to seat this on the patient, and I want to be able to look in this hole to make sure that that metal housing is seated all the way and it's not binding anywhere on this. And this is an upper. You can see the metal that actually transitions to the palate, almost like a bead that goes on there. So it really helps with the thickness. You can really get it pretty thin right there, and it helps not get so much food in there because they're still going to get food, and it just makes for a less of an area for their tongue to go. I'm going to actually end everything with my contact information here. This is my personal email. This is the office here. If you guys have any questions about anything, please don't hesitate to call me. This is fun stuff. So there's very few things in dentistry that can really change dentistry. This is one of them. Adding implants to your practice can do so much, not only for your practice, but for you personally. You know, we all go through these cycles of dentistry where you get burnt out, and you learning something new. Implants, it's so beneficial, and your patients can benefit so much. And starting with overdentures, what a great service. You know, it just makes dentures so much better. So with that, I'd like to thank everyone for joining us. And again, if you have any questions, then please feel free to either email me or call the office.